Burosumab therapy in children with X-linked hypophosphatemia. Definition of FEX gene. The FEX gene provides instructions for making an enzyme that is active primarily in bones and teeth. The FEX enzyme could be involved in regulating the balance of phosphate in the body. Among its immune functions, phosphates plays a critical role in the formation of and growth of bones in childhood and helps maintain bone strength in adults. Definition of FGF23. Fibroblast growth factor 23 is a bone-derived hormone regulating phosphate and vitamin D metabolism. The FGF23 is secreted by osteocytes or osteoblasts and works by binding the clotho-FGF receptor complex. FGF23 suppresses proximal tubular phosphate reabsorption by reducing the expression of sodium phosphate cotransporters. FGF23 also inhibits intestinal phosphate absorption by modulating the expression of vitamin D metabolizing enzyme.
Fibroblast growth factor 23. It's a hormone. It's an endocrine hormone. It's a hormone that's made in the bone and circulates and affects other organs in the body. So its primary role, as understood now, is to make the kidneys and get rid of phosphates. So it's made by the bone, it circulates, it goes to the kidneys, and it tells the kidneys to basically urinate out more phosphate to keep the body in balance. It's a normal hormone that people have. If you measure it in people, everybody has a level, some higher than others. It was originally discovered in diseases when it was very high in certain kinds of diseases like rickets, where people have very, very low phosphate levels, and turned out it was caused by very high levels of this hormone. The other condition that the hormone is very high in is kidney disease. People with kidney disease have extremely high levels of this hormone. Even though the primary role of FGF23 is to make the kidneys urinate out more phosphate, this sort of side effect or other aspect of it that seems to be happening is that it tends to be potentially trophic to the heart, and that it makes the heart, the cardiomyocytes get bigger, and it may contribute to left ventricular hypertrophy and potentially cardiovascular disease. Right now, there's nothing you can do about it. There are no, drugs or other treatments that specifically lower it. Right now, it's really it's measured and monitored in these diseases, and there's nothing no way to directly make it get lower. We've done different studies with it. One of the things that we did was we measured this hormone in about 6,000 normal people, because the information about this hormone in the general population was not well understood. It was understood in kidney disease and understood in these other rare diseases. So we measured it in this large group of people, and we related it to cardiovascular disease. And we actually found out that people whose levels tended to be higher had higher risks of heart failure and cardiovascular events during their follow-up. Well, I think one of the places that the group that's interested in this the most are the people, nephrologists or kidney disease doctors who are taking care of patients who see this and notice that the levels are extraordinarily high and are wondering what they can do about it. As of right now, probably not a lot, but that might be one of the first places in which some kind of clinical intervention takes place.
Definition: X-linked hypophosphatemia. X-linked hypophosphatemia is characterized by mutations in the FEX gene. Mutations in this gene lead to the increased secretion of fibroblast growth factor 23, which regulates the reabsorption of phosphate in the kidneys. Too much FGF23 reduces the amount of phosphate reabsorbed by kidneys, leading to hypophosphatemia and the resulting symptoms of XLH and consequently rickets, osteomalacia, and skeletal deformities. Due to FEX gene mutation is the most common genetics forms of rickets and osteomalacia. Is inherited in an X-linked dominant manner. This is because the gene responsible for the condition is located on the X chromosome, and having only one mutated copy of this gene is enough to cause the condition in both males and females. A female, which has 50% chance of passing XLH to each of her children, and male will pass to all his daughters, but no sons. Manifestations. Manifestations in children consists of rickets, lower limb bone deformities, bone pain, failure to thrive, dental abscesses, and craniocentosis. Adults may present with persistent bone pain, early osteoarthritis, hardline, fractures, and looser zones, enthesopathy, and periodontitis. Regardless of whether the patient is an infant, child, adolescent, or adult, an early diagnosis followed by optimal treatment is crucial to control the clinical manifestations, prevent complications, and improve quality of life. Symptoms. The symptoms of XLH can vary in severity. Some people with XLH have no apparent bone-related symptoms and only hypophosphatemia, while others have several symptoms. In many cases, they become apparent within the first 18 months of life, when a child begins to bear weight on the legs. Early signs and symptoms may include abnormal bone development, leading to bowing or twisting of the lower legs, and short stature or a slowing growth rate. Other symptoms may present like bone pain, muscle pain and weakness, a waning weight, joint pain caused by hardening or calcification of tendons and ligaments, abnormal tooth development, tooth abscesses and dental pain, rickets that does not improve with traditional vitamin D therapy. In some cases, the symptoms of XLH do not begin until adulthood. Symptoms may include joint pain and impaired mobility from enthesopathy, calcification of tendons, ligaments, and joint capsules, tooth abscesses, and hearing loss.
X-linked hypophosphatemia is an inherited disorder of renal phosphate wasting that leads to rickets, osteomalacia, stunted growth, and ultimately lower limb deformities, pain, and physical disability. It's caused by a genetic mutation leading to excess production of fibroblast growth factor 23, which impairs renal phosphate reabsorption and vitamin D synthesis. An open-label Phase 2 study evaluated the efficacy and safety of Burosumab, a recombinant human monoclonal antibody against FGF23, in children with X-linked hypophosphatemia. 52 children 5 to 12 years old with X-linked hypophosphatemia and active rickets were randomized to receive subcutaneous Burosumab every 2 or every 4 weeks, titrated to achieve low normal serum phosphorus levels. Follow-up measures were assessed after 40 and 64 weeks. By week 40, the mean radiographic Thatcher-Ricketts severity score decreased from a baseline of 1.9 to 0.8 with every 2-week dosing, and from a baseline of 1.7 to 1.1 with every 4-week dosing, and the improvements persisted at week 64. Mean serum phosphorus levels increased after the first dose of Burosumab. Over half of the patients attained normal levels by week 6, and the every 2-week dosing maintained stable levels through week 64. The mean standing height Z-score increased overall, patient-reported pain was reduced, and physical ability improved. Most adverse events were mild to moderate in severity. The authors conclude that for children with X-linked hypophosphatemia, Burosumab improved renal phosphate reabsorption and serum phosphorus levels, reduced rickets severity and pain, and improved growth and physical function. Full study results are available at nejm.org.
Definition of Burosumab therapy. Burosumab is an orally bioavailable recombinant human immunoglobulin G1 monoclonal antibody directed against human FGF23 that can be used to increase serum phosphate levels. Upon subcutaneous administration, Burosumab binds to and inhibits FGF23, thereby interfering with FGF23 signaling. This increases tubular phosphate reabsorption, decreases excretion of phosphate, and increases serum phosphate levels, resulting in enhanced bone mineralization. FGF23, a member of the fibroblast growth factor FGF, family produced by osteocytes, plays a key role in hypophosphatemic rickets, osteomalacia, such as X-linked hypophosphatemia and tubular-induced rickets or osteomalacia. Increased FGF23 levels lead to decreasing expressions of the sodium phosphate co-transporters in the proximal tubules, reduced renal phosphate reabsorption, increased excretion by kidneys, and low serum phosphate concentrations. Why use Burosumab in X-linked hypophosphatemia? X-linked hypophosphatemia, which results from mutations in the phosphate-regulating endopeptidase homologue gene, is the most common form of hereditary rickets. These mutations cause excessive circulating levels of FGF23 and thereby excessive FGF23 activity. This in turn reduces renal tubular reabsorption and increases renal phosphate excretion, resulting in low serum phosphate levels and ultimately impaired bone mineralization and bone disease. This also leads to poor bone mineralization, to limb deformity, short stature, osteoarthritis, insufficiency fractures, and other poor outcomes. Application in medicine. We investigated Burosumab and monoclonal antibody that targets FGF23 in patients with X-linked hypophosphatemia. In clinical trials, subcutaneous Burosumab increased serum phosphorus levels in pediatric and adult patients with XLH, as well as significantly improving the severity of rickets in children and improving pain, stiffness, physical functioning, and pseudo-fracture healing in adults. Burosumab is well tolerated by children and adults with XLH, with the most treatment-emergent adverse events being of mild to moderate severity. In this chart, we can see simplified pathophysiology of X-linked hypophosphatemia, which are in the lighter boxes, and the mechanism of action of Burosumab therapy, like a treatment, in the dark colored boxes. As we can see in the first, it decreases renal phosphate reabsorption, and Burosumab elevates the renal phosphate absorption. Also, it increases renal phosphate excretion, and Burosumab therapy decreases renal phosphate excretion. Issue applied in Ecuador. Burosumab therapy in children with X-linked hypophosphatemia cases were not found or reported in Ecuador. Pros and cons. What is pros? What is the efficacy of Burosumab in the treatment of XLH in adults? Phase 1-2 trial and extension studies. The clinical benefits of subcutaneous Burosumab once every 4 weeks in the treatment of adults were initially shown in the following small label. Dose escalation. In a number of 28 patients at day 7 after dose 1, 2, 3, and 4, which were from 0.05 to 0.6 milligrams per kilograms, maximum fasting serum phosphorus levels within the normal range of 2.5 to 4.5 milligrams per deciliters were achieved by 15, 37, and 88% of patients. Relative to baseline, at day 120, Burosumab significantly improved XL-related physical functioning, and stiffness from baseline, it improved more. In each dose cycle, maximum and minimum fasting serum phosphorus levels were within the normal range in 58 and 85%, and 25 and 43% of patients respectively. TEAS is treatment emergent adverse events. Tolerability profile. Burosumab was generally well tolerated in pediatric and adult patients with XLH, with most treatment emergent adverse events being mild to moderate in severity. No TEAS lead to treatment discontinuation, dose-limiting toxicity, or death. Cons. There were some TEAS reported, like headache in a 60%, local injection site reactions in a 59%, which include erythema, rash, rushing, pain, pruritus, swelling, discoloration, hematomas, hemorrhage, induration, urticaria, and other reactions at that site of the injection, vomiting and pyrexia, pain in extremity, any type of rash, toothache in a 22%, myalgia in a 50%, tooth abscesses in 17%, and they were common TEAS like back pain in a 15 to 9%, tooth abscesses or infections in a 13 to 8%, and headache from 13 to 8%. Conclusion. XLH is a genetic condition that causes significant skeletal deformities in children from a young age and lifelong disability and pain. Conventional therapies consist of managing symptoms and disability and supplements of oral phosphate and active vitamin D. Clinical trial evidence suggests that Burosumab provides short-term clinical benefits in children aged between 1 and 12 years. In children with X-linked hypophosphatemia, treatment with Burosumab improved renal tubular phosphate reabsorption, serum phosphorus levels, linear growth, and physical function, and reduced pain and the severity of the rickets. In the picture, we can see that from the first day they started treatment with Burosumab, at the day 64, the knee was already fixed.